RArEST, we started there. We made a list of the problems that we didn't like and then tried to come up with a couple of things that we could do to address our problems. And we sort of broadly categorized these into two things, one being education and one being networking. We thought that one of the big issues in transition from pediatric to adult services that we're seeing is that adult services don't have the knowledge or the experience of handling a lot of rare conditions. They tend to be often a little bit more centered around aged care services rather than providing children or young people with support. So we wanted to work on how we provide education to the end result. So after we've transitioned across between services, how we can make the end result better and more sort of up to date with how best to support these clients who've gone through. We talked about some educational packages or modules, things that could be easily accessible to healthcare workers, but also things like supporting parents and supporting care providers for kids in ensuring collaborative care, but also building care coordination capacity. We then thought about networking, and we thought we could set up perhaps some options for parents to network with each other, but also anyone else providing care support or care coordination support for kids as they transition through, and then to maintain that through past the transition so that it didn't just drop off and stop. We talked about how we could better communicate a client's specific needs and how that could be sort of used when they do go to a hospital or service setting, something that had the client's condition and a bit about how that presented for that person and how we can best advocate for that client when they do go to other services. And we talked about building networks for providers to support each other better.
Yes, the old story is the squeaky wheel. So as an organisation and as the people who are going to be speaking up, it's those that probably have the capacity to do that, to advocate for themselves. And there's a real need to support and advocate those that are going to go through this transition that don't know what might be available to them or how to speak up for their own needs as well. And it's a problem finding those people and making yourself aware and getting them, like I said, to be able to advocate for their own needs and transition where they just think that the health system is imposed on them and they take what they're given.
So our starting point was going to be to compare the pediatric and adult hospital care and talk to the patients, as you just heard, and the clinicians and other stakeholders to ask them, like, what is good care? Like, what do you want to see?
So just for some considerations, we did have an interesting discussion about how, as the federal government, we realised we had money and power and influence, and we're like, how do we use that best for this? But we also appreciated that our role was to think about how to make us look good with celebrities, thinking about what that meant politically, and thinking and also managing the budget. So we realised we didn't have unlimited funds. We did then talk about how to best consult/engage and get those ideas. We decided we should try to do that collaboratively with states and territories, but they said, oh yeah, we'll join you in your consultations, but you need to hear from us first as to what we want to say. So that was an interesting start to our consultations. Where we've come up with the states and territories, and I don't know how many of them are virtually standing behind me nodding yet, is we came up with a bunch of ideas to try and address these challenges. So first is our focus on having expanded transition coordinators in our tertiary hospitals. And the way that we plan to do that is also to have some sense of obligation. So we'll have a new activity-based funding item so that the states and territories will be funded to provide those transition services. With more equitable access to transition services around Australia, which today is very patchy. And we will bring with that some obligations. The states and territories will contribute data, and the Commonwealth Department of Health will monitor then not only the creation of transition plans and ensure that all people with rare diseases are getting these created for them, but also how well that they are actually then implemented. Because we think at the moment there might be some implementation challenges. So, transition plan is good, but potentially it doesn't get followed through. We also realise that we don't have all the answers yet. So we'd like to announce a funding call for projects through the MRFF to improve our understanding of the gaps today and co-design solutions with consumers and other stakeholders for new ways that we can address the challenges of transition for young people with rare diseases. And I know we've had some great conversations with some of the states and territories about their considerations for new adolescent and young adult services, and looking at how do we actually reorient some of our health services. So we're looking forward to working with the states and territories on those options through MRFF funding of implementation projects. And we know we've got a fantastic workforce of health services researchers, particularly here at Macquarie University, where we're making this announcement. The Commonwealth is also looking forward to a workforce grant for rare disease education, and we'd build that into some of the new PHN funding negotiations that are coming up in the next budget. And we'd also like to talk to the College of GPs about potential new item numbers to allow GPs to carve out time and be reimbursed for work they do to support young people transitioning with rare diseases. And the last thing we want to look at, and we'll probably start a feasibility study or something on this, is reducing the data silos that exist. Again, a collaborative project where the Commonwealth and the states will co-fund. Commonwealth will provide a lot of policy guidance, but the states and territories will need to implement. So this is raised to us in our joint consultation by allied health professionals and also primary care, that one of their biggest challenges at the moment is that they want to provide better care to their patients, but they can't see the data that they need. So we want to identify ways that we can reduce those data silos, integrating and having patient-controlled data. This goes beyond my health record, but what is the hospital data that gets left behind in the children's hospital, and how do we share that with adult physicians?
The issue of workforce, we've not come to the colleges yet. Just recently, the government has made nursing free within universities. I think the three things that come down to transition for all the conversations has been personalised, effectiveness, and supportive for the workforce, for the individual, for the families and loved ones. And those, I think, are the three critical things. So the state position for transition would be around those three factors.
The point of view of the colleges, we talked about adding in that education or during specialist training to incorporate education into rare diseases and care coordination for these children with rare diseases. And specifically in the transition phase, how we can coordinate and communicate between the paediatric services and adult services and understand exactly what is important to the patients and the families during this time. So we talked about the rapport that the paediatric services build with the parents and the patients as they are providing care for those first 18 years or so, and how we can make that transition to the adult services a little bit easier. So we talked about a new workforce to support that transition period, which would require more people, I suppose, and help with that transfer of records and history, but also support the relationship from the paediatric specialist to an adult specialist. And we also talked about the difficulty of that age kind of cutoff where we see children transition at the age of 18, but a lot of them aren't ready for that. And we talked about how intellectual disability is also involved. And can we widen that transition gap and have some kind of overlap of paediatric and adult services to simplify things or smooth things over, I suppose. I think that was one of the most important things we talked about, is how we can support children in that space where they are vulnerable for mental health, when we are dealing with the HSC and becoming independent, autonomous people and learning who they are, and also dealing with a chronic healthcare condition that a lot of their peers wouldn't be dealing with. So I think that was the crux of our things. And then we also spoke about supporting equity. If someone is 18 and chosen to live out of home, how can they support themselves to pay for specialists? How do we as specialists support them participating in their own healthcare?
Thank you. Yeah. Excellent. Thank you. Other doctors, other specialist doctors, do you have anything to add? Did they capture it?
Well, we're really excited that the federal government is going to subsidise care And so for specialist services, young adults won't have to pay the high specialist fees. And the federal government is going to support us in. So we're super excited and we're very grateful as well.
So it's about money.
Indeed, it's about money and training for us as specialists.
I guess we started by thinking about what the PHNs do and the GPs. As everyone knows, GPs are specialists in life, and so often because there is a major gap for individuals with rare disease transitioning and there's actually no adult physicians who will look after them, it is the GP who is responsible for all of their healthcare needs and is that primary frontline worker. And so we thought that to bridge that problem around lack of communication from hospitals and transition, we needed to create a special workforce, and it sounds like the specialists also think so, where there's GPs who are essentially ambassadors in rare disease. And so they're responsible for training, upskilling, and getting all of the extra resources, networks, and pathways to look after individuals with special needs. And the PHN will be responsible for rolling out those programs. And we'd be also empowering patients to look to these doctors to build relationships with them early. So we didn't have that problem where we'd get to transition and we'd ask them, who's your GP? And they wouldn't even have somebody because it'd be their paediatrician who did everything for them. So this idea around sort of national campaign around rare disease, get to know your GP for transition.
Understanding of the diagnosis, but we also understand that patients are more than just a diagnosis. We understand patients at a much more personal level. So when we thought about this, we thought, what is our critical role in ensuring that transition of the person from the pediatric care into the adult care? The first thing that we thought was, this can't just be a simple handover of a diagnosis. We need time with the care team that we'll be transitioning to really talk about the individual that is concerned and what their individual needs are. And that requires time, right? We're not talking about a single meeting to hand over or a few weeks. We're thinking it might take a year or so, working hand in hand with the adult team to transition that care.
We did go and talk to the patients. We went and talked to the doctors as well to try and understand a little bit more. And we certainly heard about this idea around an app for management of data. And we are interested in data and we're interested in getting hands on patients. So that kind of made sense to us. And we thought we're really happy to talk about some things that we could fund if we get something in response. So certainly interested in patient registries that we could fund if there's also some international collaboration. And what we really struggle with in all of the ideas that we wanted to improve is how we work with Australia and the fragmented system. Too many voices. So we love the idea of an AYA clinical trials network for rare disease like there is in cancer. We could see ourselves making some money from that and we might sponsor it.
The consumers articulated that no one was listening to them and that workforce needed an improvement in education about what the consumers actually need. Yeah, there was a knowledge gap there. So we did reach out to the workforce. The specialists had no capacity to speak to us because the federal government was there talking to them at the time. And they were actually in the way of a lot of discussions when we went around. Just noting that. The nurses initially did not want to speak to us, but then did come around and we report that they are doing their best. That they think the process is clunky and they think that MDT care is a way forward. Allied Health articulated that there is an assumption that they know what consumers needed and they have limited knowledge in what other allied health services and other services are out there to help them link up and help with the solution to this problem. The GPs needed more money. They also needed clarity on what the gap is in integration and transition. The state government articulated that there was a lack of leadership
it was a federal issue with funding and Medicare and the continuity of care, that the hospitals were limited in their providing variable services to support the consumer, and that their focus would be on improving education of the workforce. And the federal government were very deflective, and they were considering the issues. They were going to possibly have a roundtable. An announcement would be coming out soon. So some potential solutions to this problem would be industry, but they took us on a trail of this drug solution for parents. So we think that they lack insight into the issue when horizon scanning, and they should consider potentially IT solutions, and the researchers need money